and MI. MI is the big daddy. This is the big one, Ethel. Okay? This is it. This is the big one. This is where your cardiac muscle is destroyed. Okay? And it's due to an interruption of blood supply to a particular area for a period of time. Angina comes and goes. Okay? You have an interruption, but it's not for an extended period of time. It's a brief period of time. But with an MI, it's an extended period of time. How do we actually assess, or how do we actually diagnose an MI? Well, number one, history is very important. Okay, so getting the history. Chest pain for how long? All right, because the chest pain generally lasts for longer than 5 to 10 minutes. It's generally 30 minutes or longer. Okay, the pain will go to the jaw, the back, the arms. He'll get cold and clammy. Okay, there's tightness. You know the classic signs. Someone sitting on my chest, right? And the big one is what? Denial. I am not having a heart attack. Oh, yes, you are. No, I am not. Okay, he's diaphoretic and all this kind of stuff. So if a patient is having an MI and he presents to the ER right now with an MI and I do a 12-lead EKG, I can see right now that he's got one. Okay, a 12-lead EKG can show me acute changes. It can show me some non-specific. Acute changes means something that's happening now or just very recently. Okay? Non-specific changes basically are changes that occurred, well, I don't know. Could it have been last week? Could it have been last month? Could it have been a year ago? We don't know. All right? Now, maybe this could be normal. We don't know. So history is very important. Then we'll do a 12-lead EKG, we'll do a chest X-ray, and we'll definitely monitor the vital signs. The chest X-ray is essentially to take a look at the size of the heart to see if there's any cardiomyopathy, whether it's enlarged or not. Usually with an MI, if a person has an MI, there's some cardiomegaly right there, okay, which means the heart is much bigger because it's had to work very hard and it's trying, and there's usually some congestive heart failure along with it. A very important note with an MI is that somebody who has angina, you want to tell him this, watch for pain that's unrelieved by rest or sublingual nitro. Usually with angina, if he's got some chest pain, if he sits and rests, it fixes it, takes care of it, okay? If it doesn't, you've got a problem. All right? Some of your nursing interventions, well, obviously you're going to treat the arrhythmias. And you're going to monitor his electrolytes. You're going to give oxygen, relieve the pain. And what's the best drug for this? Morphine. Morphine is the drug of choice. You want to gain IV access, tell him to rest. If a patient comes in with chest pain, okay, and he wants to go to the bathroom to pee, guess what? You give him a urinal. Here you go. Here's your bathroom. Okay? You want to give him baby aspirins also. Well, aspirins is what NCLEX wants you to know. But the treatment now is to give baby aspirins, those St. Joseph aspirins, those chewable cherry flavored. And the reason is because if you give 325 milligrams of aspirin, you swallow it, goes into the stomach, what does it do? It affects your stomach, right? And then it has to get absorbed, et cetera, et cetera. By the time it finishes getting absorbed, you've got maybe 81 milligrams that's been absorbed. Whereas if you give a baby aspirin, you suck on it, you chew on it, it does not go into your stomach, it goes right into your mucosal membranes. And one baby aspirin is what? 81 milligrams. So might as well give a baby aspirin. But again, that's NCLEX not up to date yet. So, but we're getting there, folks. Okay. Another thing that you'll see done is also something called thrombolytics. We'll give streptokinase or TPA or Retavase or Integralin, one of those things. Years ago when streptokinase first came out, we used to hate it when the doctor says give streptokinase. We used to hate it because then we'd have to pull out all the pressure bandages and look at his body. Every single place there was a dot, like a little cut, we had to bandage it real tight because once we gave streptokinase, he'd start bleeding out. Well, today we've got TPA, we've got Integralin, we've got Retavase, we've got several other things that right now we can give and it doesn't cause the severe bleeding that streptokinase did. It's a wonderful, wonderful procedure, a wonderful treatment. The problem is there is a window. There is an absolute window. So you need to know, when did he get the first symptomology? Okay? Because there's a window, depending on the drug that you're giving, between 2 to 5 hours. All right? And so if it's more than the window allows, you cannot treat him with that, with a thrombolytic. All right? Let's talk about Mr. Rockwell. Is Mr. Rockwell in your book? Mr. Rockwell is a 56-year-old black male. Here's his history. His father and grandfather had hypertension, treated with meds. Okay? Mr. Rockwell has had serial blood pressures of 160 over 90, 158 over 92, and 170 over 100. He is a smoker, and he has a type A personality. He also drinks, he's overweight, he has a sedentary lifestyle, and his 24-hour dietary recall shows high unrefined sugar with an empty calorie intake. In other words, he lives on Krispy Kreme donuts. Okay? Is this guy, does he have any risk factors here? Maybe a couple? Well, as far as he's concerned, smoker, alcohol, definitely. Overweight, definitely. Sedentary lifestyle, yes. Diet, yes. Type A personality, yes. And his serial blood pressures as well, yes. Because you have to have 3. Right? 3 blood pressure readings. And the diastole must be more than 90. Now, the fact that his father and grandfather were hypertensive, treated with meds, is a significant factor as well. Right now, this young man, 56 years old, is at such a high risk for an MI. If he doesn't change at least half of his lifestyle, he may not live to see 60. So what I wanted you to do is be able to pick out the risk factors here. So where would you look and what would you do for Mr. Rockwell? Well, you're going to do a chest x-ray, obviously. You will do a fundoscopic exam. Well, not you, but the doctor will. Now, here's the thing. They're going to say, fundoscope? He's a man. He doesn't have a fundus. Not this fundus in the eyes. Okay, your eyes have also have a fundus. Each one has one. And what the doctor will do is look in the eye, and what he's looking for is to make sure there's no what we call arterial venous nicking. You know, the arterioles and the venules inside your eye cross like this, and it needs to be a clean cross. What you don't want to see is nicking at the crossing. So here's your artery, here's your venous. See how it crosses very nicely, right? What they don't want to see is that, an incomplete. There's some nicking right at the crossing where they cross. They don't want to see that, because if they see that, that's an indication of hypertension in the fundus. Okay, you're also going to do what? Draw his H&H, his labs, as I said. And we're going to do serum chemistries because we want to check his enzymes as well. And we're going to check his get a UA from him. We're going to look at cholesterol and lipid profile. I guarantee you it's high. Guaranteed. Guaranteed. Okay. Any questions there? I'm sure you all can tell me little stories about people that you know. Yes, who are all in denial. They're eating terrible things, but they're all in absolute denial. Left-sided versus right-sided. We're going to cover left-sided first and then move to right-sided. What are you going to see with left-sided failure? Well, before we do that, can we just very quickly go into this anatomy and physiology? Because trust me, it really helps if you'd understand it. The left side of your heart receives blood from where? The right side of your heart, right? Or is it from the lungs? It's from the lungs. Yes. Think about it. It's from the lungs. Whatever goes to the lungs feeds into the left side of the heart. The right side of the heart pumps the blood to the lungs. And whatever blood gets oxygenated in the lungs goes into the left side of the heart. Yes? Okay. So the left side of your heart receives blood from the lungs. All right? It receives it in the left atrium, and then it passes through the mitral valve into the left ventricle, and it's from the left ventricle that the blood gets pumped out into the system, correct? So go back now. It's receiving the blood from the lungs. What would happen if the left side of the heart was unable to pump the blood out into the system? What would happen, in other words, if the left ventricle decided, I am tired, I've had enough of this, you want me to work 24/7, 365, the pay is lousy, it sucks. I am not doing this anymore, thank you very much. Okay? I'm going to lay down right now. So left side of the heart goes on strike. Wants more money. All right? Well, guess what happens, folks? Blood backs up, doesn't it? Doesn't it back up? Sure, because the lungs don't know any better. Okay, the right side of the heart doesn't know any better. It keeps pumping blood to the lungs, and the lungs keeps returning it to the left side of the heart. So it doesn't know any better. It keeps pumping. He doesn't know he's on strike. Nobody told him. Nobody told the lungs that the left side of the heart went on strike, okay? So the lungs are going, cool, I'm just pumping this blood in. Well, you're going to have a backup, all right? Because now you're reaching the picket line. Here's the picket line now, and it still says, no, we're not taking any more blood, thank you very much. Okay, so what happens to the blood? It now backs up into the lungs, yes? So now the lungs got to go on strike too. See, they just got cornered into this thing. So now the backup goes into the lungs, so now you've got a backup of blood into the lungs, so what do you have now? Fluid overload in the lungs. Do you see how that works? Okay? All because, you didn't pay the left ventricle enough. You guys got to fix this problem. Okay, let's see what happens. So with the left-sided failure, you're going to see pulmonary problems. Yes? Shortness of breath, you're going to see fluid overload, you might see pink frothy sputum, so you're going to see pulmonary problems. All right. Right side of the heart now. Let's talk about the right side of the heart. Where does the right side of the heart receive its blood, its supply? From the body, right? Superior vena cava, inferior vena cava. Yes? Okay. So essentially, if the right side of the heart fails or decides that it wants to go on strike and it wants to stop, okay, what are you going to see? A backup of blood into the system, correct? So now you have systemic edema. Do you see how that goes? It's rather like if you were trying to go home on the BQE, all right, and there is an accident there. Now there's a blockage. Well, where is the backup of cars going to be? Beyond the blockage or before the blockage? Before, right? See? Same thing. And we all know about the BQE. Okay, so there's that blockage that occurs before. So it's the same thing with the heart. The blockage occurs before in the supply. Okay? So here are all the cars coming. Here's the blockage. Here are all the cars coming. Here's the supply of cars coming. Hits the blockage. Well, guess what? Back up now. Same thing with the heart. Here's the blood coming from the system through the superior vena cava, through the inferior vena cava, into the right side of the heart. There's a blockage in the right side of the heart, so there's a backup now, all right, into the system. And that's why with right side failure, you're going to see what? Systemic edema. You're going to see systemic problems, okay, peripheral problems. All right? Your nursing intervention for both right or left-sided failure is pretty much the same. You're going to give morphine, MS, morphine sulfate. You're going to give oxygen. Remember, the heart doesn't stop working. It works 24/7, 365 from the second you are born until the second you drop dead. Okay? So it's a very oxygen-demanding organ. It demands oxygen. And so because it's an oxygen-demanding organ, if you even deny it of one teeny bit, it will rebel. And it will tell you so. Okay? It will cause you pain. So you want to give him oxygen. You'll give him nitrates. Why nitrates? What do? Nitrates are vasodilators, aren't they? So they dilate the vessels. And in doing that, they do a couple of things. Number one, they decrease the resistance of flow through the blood, through the vessels. That's number one. And number two, it therefore decreases the pressure and the workload of the heart. All right? You want to put the person in high follows because remember, he's going to be short of breath. Okay? Eyes and nose are important. Daily weights are important. And TED hose is important. Why? Because what do TEDs do? They encourage the return of the blood from your lower extremities back into the heart. TEDs are those anti-embolic stockings. You know what I'm talking about? Those tight ones. Those white ones that have the little hole in it.